It is my privilege to introduce our guest speaker today. Sitting with today's topic, she is a previous fellowship supervisor of mine. She continues to be a role model for me and I'm sure several others in our field today. She is someone who I believe has spearheaded clinical practice and research as it pertains to our understanding and approach to neuropsychology from a very early age, and then also throughout childhood and adolescence. Dr. Heffelfinger is joining us from the Medical College of Wisconsin, where she serves as Professor of Neurology, Neurosurgery, and Pediatrics. She is the Director of Training in Neuropsychology, as well as the Clinical Section Head of Pediatric Neuropsychology. Among other things, she is the past president of the Association of Postdoctoral Programs in Clinical Neuropsychology, or APSIN, and is the current co-chair of the APSIN Committee on Diversity and Inclusion. So please welcome me in joining Dr. Heffelfinger.
Thank you very much. All right, so make sure I'm getting set up here. I'm really looking forward to spending this hour telling you guys about competencies and supervision. My goal is to, I'll whip through some of it quickly and show you where you can find more information about these topics. But what my goal is for you to understand how, when we talk about training competencies, it really is the attempt of the field over the past 3 decades to define what does it mean to be a clinical neuropsychologist and what does it mean to be a competent one at that, and how do we train and assess it, and how important supervision is around that. So my hope is to be able to touch on those 3 things: the competencies, competency-based assessment, and also the importance of supervision, because I believe relationships are the key to just about everything. And in our field, good, strong supervision is the key to making sure that we are developing competent clinical neuropsychologists. And so it's important. So let's start with why competencies matter. Well, it matters because as a field, we have to do what we say we're doing, and defining those competencies gives us a way to assess that. I find it fascinating to look at the timeline for this because for many of you, you were not born at the beginning of this discussion. I was a young kid at the beginning of this discussion, and yet neuropsychology still remains one of the youngest fields around in the areas of medicine and psychology. And so while we've been doing it for a long time as a discipline, we still are a fairly young field and still developing. So back in 1977, there were definite thought leaders in our field who started thinking about the need to define what is clinical neuropsychology as a practice. And the first guidelines were then published in the Clinical Neuropsychologist in 1987. And in those original guidelines, they actually proposed advanced competencies in clinical neuropsychology, which are not all that different from what we're doing now and what we're saying now. They've changed, of course, in time, but at that point, we were already using that term of an advanced competency in clinical neuropsychology. Other things that I think are interesting are at that point in time, it was proposed that we had to do an internship that was specific to clinical neuropsychology, that was over 50% time for neuropsychology. And the clinical work was, back in that time, being able to do research was a little bit more of a standard than the luxury it is considered today. You basically had to be doing something clinically at that point in time to call yourself a clinical neuropsychologist. So the establishment of our competencies then very quickly became both a, what are you doing as a clinical neuropsychologist, but then also how are we training clinical neuropsychologists? So APSIN, which is, as Marcia said, the Association for Postdoctoral Programs in Clinical Neuropsychology, was developed in out of the Midwest Neuropsychological Consortium in 1988. and was created as a nonprofit in 1994 after numerous other groups of people across the country came together around the idea of needing to have standards and training at postdoctoral level. The postdoctoral level is very important because it is 2 years. You have to do 2 years full-time clinical neuropsychology work in order to be a clinical neuropsychologist. Sometime around 2002, I didn't get a chance to go back and confirm it, we were designated as a specialty area in APA. So APA has health psychology or clinical psychology, and then they have certain specialties. Neuropsychology was one of the first 3 to be designated as a specialty in the early 2000s. And I mentioned here that in 2010, there was a group of, again, thought leaders who looked at, do the original kind of guidelines from the Houston Conference guidelines still pertain today? And the results of that were that that yes, the people who were trained following the Houston Conference guidelines for training felt that they were better trained than other people who may have not trained in that way, and that that it was being widely adopted across training programs across the country. The Houston Conference guidelines, in which I didn't specify, really the Houston Conference guidelines was included in that was you need 2 years postdoctoral training, internship that has 50% or more in clinical neuropsychology, and that your training needs to be around these clinical competencies, and it has to be supervised all the way through the end of that postdoctoral time. The other thing that's really kind of cool about the Houston Conference guidelines was this foresight that they had to say there are many pathways to become a clinical neuropsychologist. So if you don't have a 50% internship time for clinical neuropsychology, if you can make it up in other parts of your training, sometimes that's okay. So that basically they said that there was not one exact set path to get to be a clinical neuropsychologist, other than needing to do the equivalent of 2 years full-time focused on clinical neuropsychology. Okay, so I'm going to try to whip through this a little bit, but I think it's important for people to understand, because I found it really hard to wrap my head around how we defined our competencies in the area. So this is the cube model that was designed by Rodolphe, which is not neuropsychology specific, but rather psychology specific. It was published in 2005. And what this group of individuals proposed is that when thinking about competencies, first of all, you have to define them to be operational, meaning that you can actually know what they mean and that they are measurable. We have spent about 2.5 decades in our field on the operational part, on the defining what they are, and are just beginning to really talk as a group about how would we consider standardized measurement or assessment across sites. So what this cube model indicates is that along the top, you see something called the foundational competencies, which I think of as being the defining knowledge, skills, and attitudes that neuropsychologists have that cut across everything that we do. No matter what it is you do, you are going to be engaging in those. And then you have these foundational competencies. Then you have what are considered functional competencies, which are what we actually do. So assessment, intervention, supervision, teaching, those components of like what are our skills that we're actually using. And then the other side of the cube is the stages of professional development, which is kind of that educational progression that we go through from undergrad to graduate training, internship to postdoc training. An interesting thing in this field that is not necessarily true in other fields is that the end of your postdoc training is the conclusion of your expected training. So while you do continue to get continuing education credits in order to maintain your license across the country, most people are not licensed in neuropsychology, they're licensed in psychology. There is nothing else that currently is required in neuropsychology for continuing education after your postdoc. Okay, So these foundational competencies, which again, the foundational competencies are the ones that cut across the top of that cube and go again across everything that you do on a day-to-day basis. They include your professionalism, your relationships, and your approach to science, so that everything you do should be motivated by what we know is empirically supported from science, and then given back to your patients and implemented in that way. I'm not going to go through each of the levels of professionalism. You can see them there. The functional competencies then are the things that we do. So these are going to be the evidence-based practice, assessment, intervention, consultation, teaching, supervision, and systems. And then in each of those areas, it was broken down that there's knowledge and there's applied. So there's what you know and there's what you do. So given that I'm talking to a group of neuropsychologists, I'm assuming that you are all aware that we are a much more data-driven field. We like a lot of content. There's a lot that we have to know. There's a lot that you have to learn in order to be a neuropsychologist compared to other areas of psychology. I'm not putting down other areas of psychology, but when you think about what a neuropsychologist needs to know, you have to understand the brain systems. How do we measure and look at the brain systems? How do we look at all the other fields around us, including everything from neurology to psychiatry to pediatrics to abnormal development? There's so many different things that we have to know in neuropsychology to be competent, that knowledge base, the knowledge base we have is much higher than in a lot of other areas. And I'm going to come back to that, because when I say that we've been defining our competencies for the past 2.5 decades, I mean that, because what we did after the field created Houston Conference guidelines and said, this is what we all need to know in order to be a competent clinical neuropsychologist, then I'd have you guys reference the Ray Casserly and Roper and Bauer article from 2012, which has the list of all of the competencies that are expected in our field. If you've not seen this paper, it's excellent, and it's really fun to look through, because when you read it, you're like, yeah, I can do that. I can do that. I do that. I can do that. Like, we do so much in neuropsychology. There are so many things we have to know. It's a lot, though. It's a massive list of things. So as I'm coming down, one of the things we've been working on the last 10 years, 5 years, has been to, how do we break it down without losing the details of what we do, but to something that is digestible by APA and by training programs across the country. So the first paper there goes through that component. The 2016 paper I'm referencing here is a large group of individuals led by Aaron Nelson, and it's the guidelines for practicum training, which is the first thing that we did in neuropsychology, where we started to look at how do you assess the competencies? What is competency-based assessment, and how do we do that at the practicum level? There's been nothing yet published at the internship level, and I'll talk in a little bit about our recent paper at the postdoc level. Glenn Smith then, when he was the president of the Clinical Neuropsychology Synarchy, summarized or wrote a summary paper, basically going through everything I'm talking about here and coming up to the point in time of saying, okay, we currently have these several different ways of looking at competencies. Which one, choose one to use in your training, with the Ray Casserly being one, and then the work that we've been doing. So I don't know if you guys have, I don't think you guys have a APA accredited postdoc there. I know you have your internship, and if I'm wrong, I apologize. But one of the things that APA does that's really strong, but can also be really complicated, is require so much in order to maintain accreditation. And they have been working towards creating both competencies that are for all areas of psychology, and then also competencies that are specific to their accepted specialties, of which neuropsychology is one. So in I think it was 2015, and then we gave it to them in 2016. They had asked the Clinical Neuropsych Synarchy, which is a group of leaders from all different organizations, to come up with what would be the competencies that APA should be using. And so a group of us, led by Brad Roper and myself, came up with what would be the specific competencies that are needed for clinical neuropsychology across the country. And so we proposed them, and then that's what I'm showing here. Again, I'm not going to have enough time to go through each of the details, but you can look them up in the paper I referenced before and one coming up here. APA said that there need to be 3 levels of competencies for any accredited program. Level 1 is the set of competencies that are for any program in psychology. And this is for doctoral fellowship, doctoral internship, and fellowship as well. So they require integration of science and practice, diversity, and ethics as the 3 areas that have to be addressed. At the postdoctoral level, the assumption is that ethics has been really taken care of. So it's still there as a level 1, but where there's not as much expectation to the direct training, because it's required to be trained to be competent in ethics really by the time you're done with your internship, or by the time you're done with your graduate training plus internship. So then level 2 is really still very, very fuzzy. So like at MCW, we do not have any level 2 program specific areas. This could be, though, if we said we wanted to train specifically to like more in maybe legal or in rehab or something in addition to what we're already doing in neuropsychology, or having an extra focus that's not included in the level 3. In neuropsychology, the level 3, which are the neuropsychology specific profession-wide competencies, we really include everything that neuropsychology does, though. So for the most part, I'm hard pressed to see what you'd need to take from level 3 and put back in level 2. So level 3 is what all programs in clinical neuropsychology who are accredited need to be doing and training towards at the fellowship level. So so basically, I'm going to kind of tell you the end of this story and then walk you through it. So we proposed this as a field to APA, and then they came back like 4 years later, I think it was 2019, and said, oh, we don't necessarily, we like what you did, but we want it to be much more general and something that more programs can train to. So we're going to say that this is how we're going to present it. What do you think about that? So when you see like APA put out these calls for open comment, that's what these things are. It's important for you to pay attention to those. And if you go in and you have something that you think is important, make sure you make public comments, because these are the things that define our field going forward. And so then we came back around. Glenn Smith had just published his paper that had listed what we had suggested as being the competencies. And then they came back and said, we don't really we like them, but we don't really like them. Let's change them to be this. And then we put in another public comment, which was probably about a year ago. And so we took a look and said, well, we really want you to be a little more intensely focused on, in particular, the area of actual research. But then also in terms of some aspects of supervision, teaching, and mentoring, and also details around neuropsych assessment. And then they just came back in the last month and said, okay, this is what we're going to do. They took, I think, one of our 3 major suggestions, and now we're putting in another public comment. So I tell you this story because, first of all, this is kind of how policy works in our field and probably across any other field. It's important to get involved in these things. It's important to pay attention and really try to understand what's going on. Hard to do on an individual level because it's hard to make sense of what's happening. But then when you look at our leadership across the country from neuropsychology, you have a lot of people who have been doing this for a really long time, it might seem like I've been doing this for a really long time, but compared to some of the other people in our field, I've only been doing it for a short, teeny tiny time. It's just important to understand how it works. The other part is if you wait until an organization such as APA says, this is what your competencies are going to be, well, 25 years later, you wouldn't have any competencies. So we've also moved the field ahead with what we know is the right thing for us to be doing, publishing our information as we go, and documenting it. And some of that is in alignment with APA. I don't think anything's in like disagreement with APA. It's just not the same. And the difference is that when you think about the board certification process, or what we might aspire to in clinical neuropsychology, that has a lot more things involved than APA can require all of their training programs to do. So for example, if you have a training program that only has one fellow and has no graduate students and has nobody that they can be doing actual practicing supervision, well, then how can we say you have to have supervision as an expected competency by the time you're done with fellowship? So the field says you must learn about supervision because supervision is the driving factor of how we create neuropsychologists, and there's no other training period past this point in time. So we have to teach our fellows how to be doing supervision, and APA is saying, okay, that's true, you do, but maybe not to the same level that you're saying it. Can we require it across the country? So that's kind of the push and pull along trying to develop something I would have thought 20 years ago would have been super simple to say, well, this is of course what a clinical neuropsychologist is and does. So anyways, that was my long little rambling story to tell you kind of how we've gotten to here. These are the proposed level 3 profession-wide competencies and kind of their summary from APA. I do respect that APA was able to take what we do and break it down into these words. That's awesome because we use a lot more words to describe what we do. In fact, here we go. So lots of words here. So this is, and I'm not going to go obviously through all of this, but these are what we proposed to be the elements. So you see up at the top, the big bold is the competency, and all of the bullets are what are considered the elements that are required to do that competency. So this is for integration of science and practice. Again, I'm not going to go through all of these. I'm just going to show you what they are. Ethics and legal standards and diversity. Those are the 3 areas that are expected in all areas of psychology. Then we get into what are the level 3, which are neuropsych specialty specific competencies. And again, the competency, and this has changed in the past 10 years. It used to be that all the bullets were what we called competencies. We had maybe, 45 competencies to train to. And now it is that there's a title competency, which is the area of skills and knowledge that you have to have, and the elements are the bullets. I know it's probably really boring to you guys, but it's important to know that because it used to be that you had to work at every bullet to be at a certain level of skill, which is still sort of true, but it's at the very big level that we're now doing broad-based assessment. So professional identity and relationships and self-reflective practice. This is that area that says you have to know what you're doing. Not only do you have to know like how to be a neuropsychologist, but you have to know the impact that you have on the people around you, your patients, your colleagues, your supervisees, your supervisors. It is that meta knowledge of just being able to understand you as a person and your impact on the people around you. That helps so much to prevent professional problems from occurring and also giving you substantial amounts of meaning. So then the next area is interdisciplinary systems and consultation. This is that area of being able to accept referrals from other people, partner with other groups of practitioners and educators, medical personnel to care for our patients and care for our populations. then this is where really the meat is in neuropsychology. So much of what we train, especially at that graduate and internship level, is around assessment. Neuropsychology really is assessment, and then all of these other things around that. So this has the most detail around the elements, which is everything from how do you accept that referral, how do you figure out what you're supposed to be doing, how do you create your test list, how do you administer tests, how do you think about which tests are right to give to which people, how do you incorporate all of that with the medical records that you've reviewed, plus their psychosocial history, plus their educational history, their family history, all of those things. How do you put those pieces together to say, this is what happened when that individual started to lose memory function or had a brain injury, and how do we go forward from there? And so all of those pieces, and then, and the ability to communicate that with other people, they all fall into the assessment competency. The next area is in intervention. In intervention and neuropsychology, we usually think of this as being, how do we use what we know from empirical research in certain patient populations to inform what we tell patients to do and their families and their doctors after we have done the evaluation. It does include some amount of intervention around education and maybe doing some kind of brief treatment for, say, cognitive rehab following injury, but it is not necessarily therapy-based intervention. And then finally, the last three competencies are research, teaching, supervision, and mentoring, and management and administration. At a quick glance over, you might think, oh, well, here's research again. And then research was also pulled out as empirical science in the APA's required level 1. The difference is that APA really only requires that psychologists know how to integrate their practice or integrate empirical research into their practice, and then how to use what they learn from their practice to apply that to their to science. But it does not have anything to do with actually conducting research or really interpreting research. And so we felt it was really important, since neuropsychology is an empirical field, and we wanted to remain that way. There is criticism from some other groups that some aspects of neuropsychology, some training programs could water down that by not remaining research focused, and the importance of our field to always stay science driven, research driven is so very important. And so we keep going back and forth with APA specifically on this one to get these points into the into their requirement for specialty programs. And then teaching, supervision, and mentoring, that's getting into how we teach about our field, supervise, and the mentoring component is something I'm not going to talk much about today, but I could talk about it for a month because it's what I think is so important and so rewarding in our field if you go into an area where you have the opportunity to be doing mentoring. And then management administration. This is going to get into, can you run your business? Can you get your work done? More and more, when we first did this, we didn't include anything in there as to are you closing encounters or finishing your notes? And now that is such a huge key important thing to be able to do. If you cannot manage your work, then you cannot be a clinical neuropsychologist. There's just too much work that has to be done now that has to be finished. So that all falls into there. Okay, I know we're saving questions till the end, so if there's anything that you want to talk about with the kind of how do we define what our competencies are, you can save that question for the end. I'm going to move into our process for how are we trying to assess competencies. So competency-based assessment is the phrase that you'll hear, which means how do we assess the competencies as you're developing them as a trainee. So our framework, and this is in a, I think I don't know that it's come out in paper print yet, but it was a e-print in 2020 that we put together, the work that we did. It's an APSN work group, and we built it on these other papers that I've already referenced for you, as well as the Nelson paper on practicum training, and which had kind of been the first to set up the way to think about, the mannerism to think about, or the manner to think about assessment. I don't even know how your training program does your assessments, but when you think about all of the different times you've been evaluated since you were a kid in school, sometimes it's based on a Likert scale, 1 to 5, below average to above average, with the middle being kind of like standard. Sometimes it's based on a grading scale system, A through F. Sometimes it's based on a check, yes, you can do it, or no, you can't do it. There's so many different ways in training to say, is this person doing what they're supposed to be doing at their level of training? And it would be better if as a field we were a little bit more uniform. So what we did in this group was, first of all, look at what people are doing in our field. And then we also looked at published assessments in other fields in psychology and in medicine as well, particularly looking at psychiatry and neurology. Most of medicine has moved to the type of evaluation process that we're talking about here. What was important to us in thinking about it as well was that it remains flexible for program-specific goals, unlike a lot of the ACGME residency programs in neurology. It's very set what you have to do and what you have to train to. We are not quite that set as a field, and because we really are still, thank God, one field. Clinical neuropsychology includes, no matter which population you're working with, what age you're working with, where you're doing it. We need to have a broad range of allowing training programs control as to what they're using to teach people how to do clinical neuropsychology, but the skills and knowledge that you use to do clinical neuropsychology should be applicable in any of the settings that we might practice or learn. The other piece to this is that it has to remain developmentally, like there has to be a developmental process to how we're assessing development. So what I want to do here is just kind of, again, orient you to what we're trying to figure out how to assess. So the competency of assessment, remember that's one of the six primary areas of competency. And these are the 5 elements that you have to be able to do in order to be an independent clinical neuropsychologist. So I'm going to focus on the 4th element here. This is the table from the evaluation tool that can be used in assessment, and I'm going to show you kind of what all the different pieces mean, but I thought it might be easiest to show you up front like what it looks like first, so you can see what we're doing. I don't know I don't know if you guys are seeing, probably not, maybe now you're seeing my arrow as I move, but if not, so at the top you've got the element that we're assessing, and then you have the different stages of training and stages that you have to advance through. So stage 1 is going to be basic or intermediate, basic to intermediate. So if you were to look, if we had pulled up here the Aaron Nelson paper that's used for the practicum level, he has a stage that would really in this be stage 0, which would be kind of that beginning practicum, end of practicum, like beginning to end of practicum. So he proposed like a 7-point, I think a 7-stage scale, because we're just talking about the fellowship in this tool, and because we couldn't fit 7 on the table, we really way too messy. We just took off the ones that were before fellowship training you should be at stage 1 coming into fellowship. So this is going to be kind of an internship fellowship entry. Stage 1 is basic intermediate, stage 2 is intermediate, stage 3 intermediate proficient, 4 is proficient, and 5, we wanted to build in the idea that there are things that you continue to do, even though you don't have to do them and they aren't required for our field of practice. There are such things as advanced levels of performance or specialty areas within our field. So target for completion should be somewhere around here. So stage 4 for proficient. So again, if we're going back to, this is about how do you communicate the results of your neuropsychological evaluation, both orally and in writing, in an accurate, helpful, and understandable manner, sensitive to a range of audiences. So again, lots and lots of stuff in here. Coming into fellowship, we expect that people should be able to accurately communicate their test results and their conclusions, both orally and orally in supervision and in a written report. And then we expect that you're going to go from that up to writing, and again, I don't have to read this all to you, but writing well conceptually, clearly written documentation, flexibly tailored for a target audience. So being able to write differently for the medical note versus the parent or family. And then the second part down here gets into all of those little details of like sensitivity to the individual needs of the patient, consideration for demographic factors, the patient's cognitive status, their psychiatric state, who you're talking to. So there's a big difference in the skill level that one typically develops during the fellowship. And one more note here, because I'm not sure, I think I have it on an upcoming slide, but the other thing that's important here is that that you develop in your abilities as you're going through fellowship. And this allows for a developmental range over the 24 months that you are there. And this empty line here is where you could put in, if for your training program, if you want someone to get there sooner, which I'll show you in a minute. Okay, so the milestones are what all of the individual pieces are. So I'm going to show you that again in a second. So the milestones are the specific targets of knowledge, skills, behavior per element and per competency. This was one of the more fun and also one of the very overwhelming pieces, because we took a massive amount of elements and said that already had way too many pieces to them. And then we said, well, what are the actual behaviors that we have to be able to measure in order to understand if someone is competent in this area? And so we had to come up with that, and we have a long way to go. When we published the paper, if you haven't seen it, one of the big things we said is, let's just practice this, and everybody just take notes. Like, what do you think is a better behavior to measure? Can we make it more simple? Because we would have been spending another probably 5 years trying to figure out how do we all come up with what these things actually are. We just wanted to get this out as a concept and as something that people can try to use into practice. And I'm going to show you the milestones again in a second. The other piece I want to make sure that everybody understands is, again, that role of supervision. So supervision is required for everything that happens in the fellowship level. What changes over time is how much supervision might be needed to know that somebody is able to do that work. And at the end of the fellowship, the benchmark equals proficient, the proficient level for independent practice. Okay, so each bullet point is a target milestone. So when you are doing your assessment for a trainee, what you would basically do is look and say, yep, they can do this, they can do this, this is emerging. So you would then say they have basically finished stage 3 and are emerging into stage 4 or into proficiency. Here are the stages. This is kind of defining what is expected at each stage. I'm not going to go through each one, but I'm going to just show you the range of development that's expected from the beginning to the end of fellowship. So at stage 1, an individual should have basic foundational knowledge and or skills in the competency. Modeling and ongoing direct supervision is needed. Stage 4 would be has knowledge and or skills sufficient to function autonomously in nearly all situations, knows limits of abilities, and seeks consultation and supervision as needed. Super important there. Seeks consultation, supervision as needed. Remember, I said earlier, you have to have awareness of what you know, who you are, and what you're doing. I have to always know when I need help. Even at this stage, I've been doing this for 25 years. Well, not 25 total, but 25 since I was in the fellowship program. And I still have to think to myself, when do I need to get help? Because I don't know what to do in this situation. And it still happens many, many times in a year. So it's not that when you're done with your fellowship, you're supposed to be able to be independent without help. You're supposed to be independent at knowing when you need help. Okay, so on this one, what I put in here is just each program can go through and indicate, you look here at that second row, program specific time benchmark, or in the lingo of APA and MLA is the minimum level of achievement. So APA requires that for every stage of assessment, 6-month, 12-month, 18-month, and 24-month, there is a minimum level that you are going to be able to do. And if you are not at that level, then you need to put additional training, time, and energy to kind of push that through. It took me forever to wrap my head around what that means, but really it's so important to training because it's kind of that, like, we all have certain things that we might not be focusing on in our development in every part of our life. That allows for us to say, okay, you need to put a little bit more energy into this area of training, into these elements for this competency so that we can make sure that you develop those skills. Not all programs have to have that. This is where, if you put that in there, you can say, if you are not at the 12-month level meeting these milestones, then we're going to spend some more time focusing on that. We're going to write it down. We're going to write down what you're going to do. And we're going to make sure that we push you up to be proficient versus letting you go before you have those skills and that knowledge. Okay, so in the tool for this assessment, there's a place where you could write your own table if you had some things that weren't in there. But again, I think there's more than enough. I am not going to focus on this one for more than a second, just because I want to make sure to give supervision a good solid 5 to 8 minutes of talking about it. But in the and we're revising this now, but the elements in these milestones are listed for individual and cultural diversity are really useful right now, because every program should be thinking about, am I teaching and training sufficiently around cultural diversity, racism, and integration and inclusion, and in all areas of our field. And that's a different topic that, again, I will talk about at some other time. But these milestones give a good start for us to be thinking about how are we training our students, our trainees, to become competent at understanding and applying individual and cultural diversity in their work on a day-to-day basis. Okay, so moving into supervision. I like to think about supervision more from the standpoint of the supervisory relationship than just a concept of supervision. Because everything we really do, you can learn a lot in books, you can learn a lot by practicing, but really evolving that component of yourself to be the best you can be and to understand yourself the best you can be, really hard to do that outside of a strong supervisory relationship. So supervision is something that historically we have kind of thought of as, like, some people are really good at supervision. You're just naturally gifted at supervision, but maybe it's not something we taught. Now we need to be teaching it and training it and believing that everybody can become a strong supervisor, just like they can become a strong neuropsychologist. Now, not everybody who's a good neuropsychologist is a good supervisor. And that's what we're trying to do by addressing supervision as an actual competence that you need to have. Another very important piece to this is that supervision is what protects the public. Many of you trainees have probably not yet had the experience, although you might have had a classmate at some point in time in training where you were like, that person is not actually going to be safe to be with patients. They might, for whatever reason, not be able to be competent in the area that they're going into, whether it's neuropsychology or some other area. Whose job is it to make sure that there aren't incompetent neuropsychologists? It's mine. It's yours. It is anyone who's involved in training. It is our job to make sure. So we often might say, oh, well, I don't want to hurt the trainee's feelings by saying, I don't think you can be a neuropsychologist. But you know what? If I don't say that you can't be a neuropsychologist after you've demonstrated that you are not able to learn learn how to do it, then who's going to? Nobody, because at the fellowship level, I am the end. The training directors for the fellowship are the end of what is required. You don't even, because you can practice as a neuropsychologist without getting board certified. So if you finish your training and you can get a license, then you can practice. And I will tell you, if you're going to go on and send other trainees to me, nothing more frustrating to me than someone who says, this person is top notch, stellar graduate student. They did a great job. And then they get here and they don't. And they really, really struggle. Always be honest with each other about things. And I'm not saying that people shouldn't have a chance. In fact, in all of my years of training, I think that an adult and pediatric practice here, I think we've had maybe 2 people out of 110 now that were not competent to be able to be neuropsychologists. So the majority of people, when they get to the fellowship level, can be trained to be clinical neuropsychologists. But if we don't catch those who shouldn't be, that is a danger to the public. Okay, so what I want to talk about here is not APA stuff, but I'm going to show you here just as I'm going through. So APA put out a set of guidelines on supervision that are quite fascinating and really, really good at guiding in supervision. They require these domains in supervision that focus on supervisory competence, diversity, relationships, professionalism, the assessment of how someone is doing through your supervisory relationship, and then dealing with problems in professional competence, ethics, legal, regulatory. So I'm going to go to neuropsychology here. I can provide these slides later for you guys if you want to read all of the work that's been done with APA here. I want to come into kind of the area of neuropsychology specific in supervision, because these are the things that are specific to us. So neuropsychology has always led the way in policy and guidelines around training and practice. And supervision is one of the core domains. It has been defined that way since Houston Conference guidelines. Teaching and supervision is one of our 5 core skills. It is listed as one of the 5 activities in neuropsychology. That said, the active supervision and the skills of supervision in neuropsychology are a little different than what is needed in to supervise psychotherapy. There are some things that probably are very overlapping. But supervision and assessment is different. And we actually have had to work really hard as a field to get APA to recognize that it is different, that we can't just have 1 hour a week where you bring your patients and talk about it. You need to have more of a hip to hip or a increased flexibility, open door, because you need to be able to check in during the assessment process, during things to understand what's going on with the patient and to provide adequate supervision. It can't always wait. Plus, we have a heavy focus on learning. like I said, there's so much knowledge we have to know that a lot of supervision occurs as part of kind of didactics and training, and teaching should count for supervision. And we've really helped influence that idea that teaching and supervision are similar. So this is what is listed currently in our proposed elements for supervision. I've highlighted the ones that kind of show the progression that you should be making throughout your fellowship in learning how to engage in supervision and also how to do supervision. I don't know how your program has supervision built in, but it should have both of those, like at the fellowship level, being able to openly accept and learn from the supervision process that is being given to you, while also having the opportunity to supervise trainees, if you have interns that you're able to supervise, or graduate students, or even people who are doing testing or research support. That is all a piece of the supervision puzzle. And then the ending point that you're really working for is, trying to get over there, being able to engage in supervision that is developmentally appropriate, culturally competent, and tailored to the supervisee. This is the goal. This is the, like, if you can do this, you are going to be able to be a strong supervisor throughout your career. So when the process of supervision, and I am just about done here, is going back to kind of, it needs to be process-based and a developmental approach. So when you are supervising others, you want to be thinking about the process that you're providing supervision, and that we model multiple roles consistently as a neuropsychologist. And then also in this developmental approach of increasing the activities and of what the trainee is doing for supervision. And qualities of, and I'll end on this one, actually it's my last slide, so it's perfect. Qualities of an effective supervisor include having interest in training, being available, being flexible, respecting the trainees, being supportive, not overly critical or punitive, but also cultivating an honest, trusting, collaborative relationship where you can help the trainee accept hard to hear information about them so that they can become a better clinical neuropsychologists themselves. All right. I have a couple minutes here for any questions or thoughts. Hope I didn't lose all of you.